Okay, so for those of you I haven't met, my name's Jason. I am the chief here at the Rapid Access Clinic, but I'm actually a future hospitalist in disguise. So I love, just, patient care, teaching people how to, think through things and kind of be better doctors, if you will. And so I'm super excited about this case conference today because we get to basically talk exactly about that as it relates to a rapid response. And this is a real case that happened a couple of years ago. So without further ado, let's dive right in. So you are working a busy swing shift at the hospital. Your first admission was a patient with cellulitis who you saw and for whom you have put in basic admission orders. Your second admission is a patient with AKI on CKD who is otherwise stable. You've just stepped out of his room to put in admission orders and write your notes when the triagist pages you. New outside hospital transfer, just arrived on the floor, transfer acceptance note in the chart. Now in real life, they gave you the patient's name and room number, but I didn't care to make those up. So this is the general information that you're getting, okay? So in this case, we're not gonna do think, pair, share. I'll just kind of open it up to the room. When should you, as far as timing is concerned, ask the nurse for vitals? What do you guys think? When should you, with this information, when should you call the nurse and ask them for a set of vitals? Right. Okay, I heard right away. Marissa, why do you think we should do this right away?
Because that gives you a better impression of like stable or unstable and whether you can like turn some orders.
Great. Great. I completely agree. So we're saying it gives you a sense of whether they're stable or unstable. If they're unstable, you may prioritize seeing them earlier or putting in earlier orders earlier. Tell me this now. This person is an outside hospital transfer. How, when you're triaging patients, like how does that differ for you as opposed to someone coming through the ED? If any, if at all.
Sometimes, well, it depends if they're just coming here to like get placement through the VA, but a lot of times like they're coming from another place that couldn't manage them, so they're coming for a higher level of care.
Sure.
Which makes me like think maybe they'll be sicker.
Sure. Okay. So coming from another place, obviously being escalated to higher level of care in most cases, so they may be sicker. Does anyone else in the room, have thoughts on how an outside hospital transfer, a direct admission, might be different as far as like triaging them when they're an admission for you, as opposed to the ED?
You usually stabilize them.
Yeah.
And at this point, they're just like, oh,
yeah.
Yeah.
So the ED, obviously they're being evaluated by a physician or an APP. They're getting vitals checked. They're sometimes getting labs checked. Initial management is put into place. So they've already been evaluated. And if they are in fact red hot and super unstable, you usually have some heads up on them at the very least. In this case, outside hospital transfers, direct admissions, they simply arrive to their room and no doctor or APP in the hospital has usually seen the patient. So when should you ask the nurse for vitals? I completely agree with Dr. Martin. We should ask for this immediately to kind of get a sense of what we're dealing with. Okay.
And they're like two directors or anything that won't be orders.
What's that?
There won't be any orders for like if they're ventilated or on.
Yeah, yep. So if there are Dr. Marr is pointing out that, if they're already on a ventilator, if they're already on drips, those orders are not necessarily going to be in already. So they may need some like early orders right away. So when you ask the nurse for vitals, you can also kind of ask if there's anything that they need. Okay. So we ask for vitals right away, immediately, no matter what you're doing, essentially. Under what time frame should we be laying eyes on the patient and kind of briefly reviewing the chart? What's like the time frame that you have in your mind? On this outside hospital transfer who just hit the floor. Just throw a number out there.
Start going to review them in an hour.
Okay, so within an hour. And I think that's good. This is no hard and fast rule. There's no official guideline on this. So what I said is as soon as possible and definitely within 30 minutes. And one thing that I want to clarify is this does not have to be your whole history. This doesn't even necessarily need to be going into the room. But I think there's value in within 30 minutes walking by the room, taking a peek in, maybe even saying hi and introducing yourself to the patient if you have time to do so, because it's a fundamentally different experience if a person is sitting there flipping through channels on the TV versus if they're unresponsive, versus if they're agonizing in pain. It can actually buy you time and ensure great patient care if you just go by the room, take a peek in, and just make sure you're not dealing with like a horrible situation. And if you do that, it's totally appropriate to set expectations with both the patient and the nurse, like, hey, I'm going to come back later, I'm going to ask you a lot of questions, I'm taking care of some other patients right now. It's okay to let a patient know that you're also taking care of other patients, but that you will be back later and give them the time they need. In a similar way, reviewing the chart briefly is also important, because maybe this person is being admitted for a certain intervention that you want to get going sooner rather than later. Maybe this person is being admitted for expedited subspecialty consultation that you want to get going sooner rather than later, and not find out 4 hours later. Okay. All right. What about, and again, just like what would you think is your time frame for putting in basic admission orders? Pain meds, diet if they can have one. Like, what's kind of your deadline in your head? Hour. Okay, I tend to agree with that. That's kind of my time frame. Sometimes hopefully it's faster than this. Sometimes it's slower than this on a particular busy day. But when I'm admitting a patient to the hospital, I try to get at least basic fundamental orders for them to exist in the hospital without big problems within an hour. And then to the point that we already talked about earlier, what's your time frame for interviewing? So like doing your full history and doing kind of the full exam of the patient if they are otherwise stable. Yeah, I say as soon as you have time. I try to do it within a couple hours, and if I can do it within half an hour because I'm free, great. But there's some swing shifts at certain hospitals where you get 5, 6 admissions all within a couple hours, and it does take a few hours before you're able to go there and really spend the time with the patient that you need. But as long as you're doing these first few things, looking at their vitals, laying eyes on the patient, reading through the chart, putting in basic admission orders, and kind of opening up the lines of communication with the nurse, this buys you the time so that if you see, go do your history a few hours later on a particular busy day, it's no big deal. Does anyone have any questions about this? Great. Okay. So you ask the nurse to check vitals, and you're ready to go lay eyes on the patient. Before you do, you briefly review the transfer acceptance note. And this is what it says. This is a 73-year-old gentleman with a past medical history of metastatic melanoma. They requested transfer from an outside ED for sepsis. He was brought in by ambulance there after being found down all night and saying he was too weak to get up on his own. Initial workup included a CT chest, abdomen, and pelvis that was concerning for right greater than left multifocal pneumonia and lymphadenopathy. And he was started on vancomycin and ceftriaxone. He was given 3 liters of IV fluids, and then his oxygen requirements gradually increased to 6 liters prior to transfer. So you are walking to the room when the nurse sends you an urgent page. Blood pressure 60s over palp. Other vitals, temperature 36.7, pulse 79, respiratory rate 24, oxygen saturation 94% on 6 liters. Now, this is more of a fun fact than anything else, but does anyone know what that means, 60s over palp? What does that mean? Anyone an EMT before, because this is something they commonly. So 60s over palp basically means they put the blood pressure cuff on the patient's arm and they're checking the radial pulse. And at 60 millimeters of mercury, they can't feel the pulse anymore. So it's basically their systolic blood pressure is 60s and their diastolic pressure is something lower than that. Okay, so that's what that means, 60s over palp. More of a fun fact than anything. Okay, so you personally experience a premature ventricular contraction, pick up the pace of your walking, and ultimately enter the room. Okay, so can we all agree that this is essentially a rapid response? Okay, this is a rapid response scenario. Okay, they haven't called the code, but this patient is sick. Okay, and they require urgent actually emergent evaluation and intervention. So first question for the group, or I guess the next question for the room. As you enter the room, should you ask what's going on? Okay, let's talk about this. No, you should not ask what's going on, because when you go in the room, there's some things that you need to figure out right away. By asking what's going on, you're going to get a whole bunch of information. Some of it might be helpful now, most of it might be helpful later. Some of it won't be helpful at all. And there'll be multiple people talking at you. They'll be telling you about the person's diabetes. They'll be telling you about the fact that a couple days ago they vomited, and none of this matters in this very moment. So what does matter? So let's talk about ABCs, okay? This is kind of how I approach the ABCs. I take a first pass where I actually, just the way it makes sense in my head, I go CBA, and what I'm looking for are any of my ABCs critically compromised. What do I mean by that? So as far as circulation, do they have a pulse? Sometimes I barge into the room, I say, hi, my name is Jason, do they have a pulse? That's actually what I do in code situations, okay? For breathing, are they breathing? Are they breathing at all? And then as far as airway, are they protecting their airway? So that's kind of my first pass through the ABCs. Because if any of those things are no, you're going to spring into action, right? Do they have a pulse? No. All right, let's see. Should we gotta be no? You gotta start chest compressions, right? So then I actually take a second pass through my ABCs, okay? And I look for things that are partially compromised. So as far as their airway, do they have like a threatened airway? They're protecting it now, but they're kind of coughing on their secretions. They're so zonked out that they're like too somnolent to breathe. Breathing, are they breathing normally? So even if they're still breathing, they have some dysregulated breathing pattern. And then as far as circulation, are they hypotensive? Are they tachycardic? Or otherwise showing signs of hemodynamic compromise? Does anyone have any questions about this? Great. So let me go step on my small soapbox about indications for higher level of care. One thing that I really want to build all of your confidence in is how to effectively triage patients to higher level of care. In reality, there is going to be some stress, there's going to be some anxiety, there's going to be maybe even some emotions, maybe some fear. But I want you to be able to wade through that and kind of on a professional level, establish if someone needs higher level of care, okay? So I put it into basically 3 buckets, okay? 1, the patient needs an intervention not deliverable at the current level of care, okay? They have shock, they need vasopressors, they're on the floor. I cannot give them vasopressors on the floor. For that reason, they need to be in the ICU, okay? 2, they need monitoring or nursing care not deliverable at the current level of care, okay? So this person needs Q1 hour glucose checks. This person is requiring such frequent lab, other lab draws. This person needs Q1 hour neurochecks. It's not deliverable on the floor, so they need to be escalated to higher level of care. Okay, and then the third one is the most salty, but it is someone who has a rapid trajectory towards number 1 or number 2. So maybe right now they're on 6 liters of oxygen and they can do that on the floor, but an hour ago they were on no oxygen and they're tripoding and they're starting to turn a little bit gray. So even though I can technically give them the amount of oxygen they need right now, they have a trajectory towards needing intubation. I am, giving them the 3rd liter of fluid and I hope it works, but their blood pressure is still 60s over 40s. I think they might need vasopressors. We're gonna get the MICU to come evaluate them for potential transfer, okay? So I think the key point here is if you can think about your transfers in these terms, it's going to give you a lot more street cred when you're calling either from clinic to the hospital, from the ED to the floor, from the floor to the ICU. Your rationale for transferring them, and then it puts the ball in their court. They can always come back to you and kind of disagree with your assessment, but then they're not disagreeing with your emotions, which is a hard situation to be in. Does anyone have any questions about this? Great. Okay, now you can ask what's going on. So what's going on with this guy? So pretty straightforward, not complicated in any way. This is a 73-year-old gentleman with a past medical history of metastatic melanoma with hepatic and brain metastases, currently on treatment with, oh man, I practiced last night, but I don't know if I'm gonna be able to do this. Atezolizumab and cobimetinib. He's on chronic maintenance therapy with that for more than 1 year. He was previously treated with ipilimumab and nivolumab, And these were actually discontinued because he got drug-induced pneumonitis, asymptomatic drug-induced cardiomyopathy, and drug-induced adrenal insufficiency. And then he has a chronic DVT on DOAC. So don't want to go on too big of a tangent, but ipilimumab and nivolumab are immune checkpoint inhibitors. When you think of complications of immune checkpoint inhibitors, think about any organ, add itis to the end of it. It causes it can cause inflammation of any organ as an adverse effect. So this is what happened with this gentleman. Okay, so what stands out just in this paragraph alone of potential reasons why this gentleman could be acutely decompensated, specifically newly hypotensive? What stands out? Okay, so they potentially didn't give him his steroids. What if I told you, because he's adrenal insufficient, completely agree there. What if I told you that at baseline he takes prednisone 5 daily for adrenal insufficiency, and he's still taking his prednisone 5 daily for adrenal insufficiency? Yeah, so now he's in an acute stress state. Normally, the way your body would respond to it is your adrenal glands would crank out more cortisol. But in someone who's adrenally insufficient, they're not able to produce kind of a cortisol surge when they're under states of stress. Okay. Anything else? I don't want to belabor the point, but anything else in this kind of paragraph why someone could go hypotensive if things were getting worse? Yes, brain mets. He could have some kind of central, like neurogenic process. Excellent. Yes, he has cardiomyopathy, so it could be getting worse. He could have had some acute on chronic cardiac event with, kind of poor protoplasm to begin with. Great. Those were the big highlights that I wanted you to see. So what we're doing, I'm not going to make you to spell it out, but you're already forming a differential diagnosis of what you think may be going on. Oh, one more thing that I think is worth pointing out. This guy's on all these immunosuppressants. So is this guy like primed for some kind of weird sepsis? Yeah. So that's the other thing that I would put into your differential. So maybe, go ahead. PE, yeah, so he has a history of chronic DVT, he's on a DOAC. Okay, so we have like a good rationalized kind of 4-item differential diagnosis that I think we can work with. Let's talk about adrenal insufficiency. The first thing we noticed, and I'm proud of you guys for noticing it. So when we diagnose adrenal insufficiency, let's talk about AM cortisol, because this is usually what people order. AM cortisol, if it's less than 5, it has really good positive predictive value for adrenal insufficiency. So you can be done with just an AM cortisol if you're lucky enough that it's less than 5. If it's greater than 20, on the flip side, it has a really good negative predictive value for adrenal insufficiency. So if you're lucky enough that it's more than 20, then you're done. I don't know about you guys, I'm not the most lucky person. It almost always, for me, falls between 5 and 20, and that is indeterminate for adrenal insufficiency. So the gold standard test is an ACTH or Cousin-Drovin's, the brand name stimulation test, okay? And what you're looking for is you give them some ACTH, and then an hour later, the cortisol should be above kind of 18 to 20. And if it's not, that is diagnostic for adrenal insufficiency. Is there any situation you could think of, maybe that applies to this patient, where a random cortisol might be useful? I missed the last part of that.
You have a critical illness, which is like a stress event, and it comes back less than 5.
Exactly. I couldn't keep up with you, Dr. Nkusi. So critical illness was the answer. And yeah, that's right, because we would expect, physiologically under a stress situation for you to have a cortisol surge. So if you check a cortisol when someone's in shock and it's 11, then they are probably adrenal insufficient, okay? So really it's like shock states, essentially. In this case, we did not check a random cortisol, me and my co-resident at the time, but it would have been interesting to see what his was. So the most common cause of adrenal insufficiency, we're not gonna go in every different cause of it for the purposes of this talk, but the most common cause is adrenal suppression due to exogenous corticosteroids. So who is at risk for adrenal insufficiency from exogenous corticosteroids? How much for how long?
20 for greater than a month or so.
Yeah, so most commonly it's folks on prednisone more than 20 for more than a few weeks. That's like most common. Technically, anyone who's on a super physiological daily dose of more than 5 for more than 3 weeks is at risk for adrenal insufficiency. But you're totally right. It's actually usually with higher doses. But I want this to be on your radar, even if someone's on 10 or 7.5, they're technically at risk for adrenal axis suppression. And these folks are at risk for adrenal crisis during acute illness. So in this case, though, a little bit different situation. He's not suppressed from his steroids, right? He doesn't make steroids because of his kind of autoimmune adrenal insufficiency. So he similarly is not able to, mount a cortisol response during stress. Okay. I want to talk about systemic steroids really quickly because I think it's really helpful to just kind of understand the common steroids that we prescribe. What is a physiologic dose? And then it gives you some kind of finesse as you're thinking about or moving between them. So let's look right here on the screen at prednisone 5. That is a physiologic dose of prednisone. So someone who is on 5 milligrams of prednisone, it's not suppressing their adrenal axis. And if someone is adrenal insufficient, that's usually what they need on a daily basis, okay, when they're not under stress. So all of these doses kind of going from top to bottom are the equivalent physiologic dose. So hydrocortisone, a physiologic dose of that is 20. It can be given in IV form. In the ICU, when you give hydrocortisone for shock, how much are you giving? So you're giving either 100 3 times daily. Sometimes we give 50 4 times daily. So 200 to 300 total per day. Okay, so let's keep that in the back of our minds. Prednisolone, fun fact, is the active metabolite of prednisone. When have you guys seen prednisolone used, if at all? For what medical issues do we use prednisolone? So ALCAP, it is the traditional medication used for ALCAP, falling out of favor due to the data from the STOPA trial, among other things. Why might that be? Oh, because the liver metabolizes prednisone into its active metabolite prednisolone. So if your liver doesn't work, you're not going to be able to do that. That's why we do that. Methylprednisolone can be given IV or PO form. So when you see folks getting 125 of IV methylprednisolone for a COPD exacerbation, think about how much steroid that actually is. And then last but not least, dexamethasone. So look at this, 0.75 is physiologic. So when we do a dexamethasone suppression test, we're giving them 1 milligram. It's just over physiologic dose to try to, suppress a kind of a normal adrenal gland. And then we do the high dose of 8 milligrams for like a ectopic source. So see, it all makes sense when you kind of put it together. Dexamethasone can be given IV or PO, really commonly used in the oncology world. And then it is not picked up by cortisol immunoassays. So if you're trying to address adrenal insufficiency, they need steroid, but you're still trying to do your AM cortisol or whatever, you can give them dexamethasone in the meantime. And same thing when you're doing the dexamethasone suppression test too. It shouldn't drive up the cortisol levels that you're measuring during the dexamethasone suppression test. It's not picked up by the assay. Any questions about this? Oh, and last thing on this slide. So what does stress dose mean? So kind of varying definitions, hand wavy between both surgical and medical literature, but we generally think about this as 5 to 10 times physiologic dose. The endocrinologist here will tell you that's at least 10 times physiologic dose. So again, let's go back to that hydrocortisone that we give in the ICU. It's 200 to 300 total divided into doses. Well, that's 10 times, 20 milligrams is physiologic. So again, steroids, it all makes sense. If you know these things, it kind of gives you some finesse moving between them. Any questions about this? All right. So last kind of topic I want to touch on is steroid-induced hyperglycemia. So it's really common that we give patients steroids in the hospital, and then lo and behold, their blood sugars are up. So if you're giving someone prednisone, a single daily dose of prednisone, or really any of these short or intermediate acting glucocorticoids, consider using prednisone. And why? Well, look at the curve of onset and duration of prednisone and look at the onset and curve, like duration curve of NPH. Okay, so if you give them an NPH dose timed with their prednisone dose, you can essentially, if dosed properly, offset the steroid effect. So you can work over the top if someone is diabetic. If they're not diabetic, you can just give them NPH. And then this is kind of a table that was developed by Dr. McDermott, who's one of a really great endocrinologist at the U, which kind of gives you a framework of how to initially dose the NPH. There's also some good articles online about how to dose NPH for steroid-induced hyperglycemia. Key thing here is you have to have explicit orders to stop the NPH. If the steroids are held, stop, not taken, because you don't want your patient spitting out their prednisone, then they get the NPH shot and their blood sugars are 12. But I think it's worth doing. You also don't want someone hanging on the hospital blood sugars of 500 when you could give them some NPH and offset it. Okay, and then if you're dealing with longer acting steroids such as dexamethasone, then you can just give them glargine or detamir because dexamethasone lasts for about 24 hours. Okay, any questions here? Case conclusion, guys. I told you this was a quick conference. So the patient was transferred to the MICU for shock and presumed impending need for vasopressors and progressive respiratory decompensation requiring BiPAP. So think about those indications for higher level of care, okay? This is why we told them they needed to go to the MICU. Actually, my co-resident told me, the MICU resident, that they needed to come to the MICU, and I agree. He acutely developed rapid AFib to sustained heart rates in the 150s that resolved with 150 milligrams of amiodarone ×1 and ongoing resuscitation. He received an additional 1 liter of IV fluids. Blood cultures were drawn. He was started on vancomycin and cefepime. And we put our heads together and we figured out that he probably needed a little bit of steroids. So we gave him hydrocortisone and we ordered 50 milligrams IV Q6 hours. With these interventions, the patient quickly improved. Further review of the CT scans and a repeat chest x-ray, remember they were worried about pneumonia, demonstrated essentially stable right greater than left fibrotic changes secondary to his known drug-induced pneumonitis. He had a repeat echo. Remember we were worried about myocarditis. He had an EF of 48%, was 52%. Previously, he was never volume overloaded. And then cultures, fungal studies were negative. Erring on the side of caution in this immunosuppressed gentleman. They did narrow him to ceftriaxone, but did complete a 7-day course of antibiotics for, again, this was still community-acquired pneumonia. He had never, been in the hospital right before this. And then he was discharged on a prednisone taper, and he did well for a little bit of time. Obviously, his underlying disease with metastatic melanoma, he got sicker, but like a year later. Okay. So take home points from. Oh, does anyone have any questions about this? Okay. So take home points. Ask for vitals and lay eyes on direct admissions and outside hospital transfers ASAP. You were the first doctor or provider to evaluate this patient in the hospital most times. So do that right away. It'll buy you time to come back and see them later and handle your other admissions while ensuring patient safety. Prioritize and systemize your evaluation of patients in a rapid response. You're going to be the most calm person in the room sometimes, and you need to kind of be the voice of reason. Recognize and convey the 3 indications for higher level of care. Diagnose adrenal insufficiency using an ACTH simulation test. And these got sync together. So there's 2 more. So understand physiologic, supraphysiologic, and stress doses of steroids. And finally, treat steroid-induced hyperglycemia unless it's dexamethasone with NPH. That's all I got. Who has any questions? Well, thank you so much, guys. I'll be hanging out here if you guys have any. Okay. Thank you. I really appreciate it.